welcome everybody to the January meeting of the Planning Council. My name is Lindell Urbano. I'm the community co-chair, it's great to see everybody. And to get started, I'd like to go around. I'd like to actually acknowledge the really good turnout we have from the public, and thank you for coming out. If anybody wanted to give public comment, there will be time for this meeting. I just want to forewarn you that we're going to keep the public comments short, a minute and a half tops, we will ask you to stop and cut you off if you try to go over that. Okay, and that's not meant to be disrespectful in any way. It's just so that we get through the meeting, right? But we value your comments. Right? Thank you. So I'd like to go around the room and begin introductions. And I'd like to start here to my right.
Hello, I'm Jan Park. I am the governmental chair of the Planning Council.
Julie Lehane, representing Tri-County Region for Tom Pettigrew.
Good afternoon, Darrell Wong, HW Planning Council staff.
Nina Rothschild, Planning Council staff.
Randall Bruce, Consumer at Large.
Harry Davis, LGBT Community Center, co-chair needs assessment.
Daniel Castellanos, Partnership for the Homeless, co-chair of the Needs Assessment Committee.
Janine Cosley, Clinical Director at the Tillery Street Women's Shelter. Amanda Lugg, Director of Advocacy African Services and member of the PSRA Committee and Policy Committee.
Rachel Miller, Public Health Solutions. Good afternoon, Christopher Joseph from Woodhull Medical Center. I'm also the co-chair of the Integration of Care Committee.
Sharon Duke, ASC NYC, and co-chair of PSRA. And ASU just moved, and I have little cards for you all.
Good afternoon, Freddy Morano. I work with Community Healthcare Network, and I sit on the Priority Service Committee.
Saul Reyes, Consumer Committee. Sam Rivera, Executive Director, UCHAPS and PSRA.
Faye Barrett, Ryan Center, and Needs Assessment Committee.
Daphne Hazel, member of IOC Committee and chair of Rules and Membership Committee.
Michelle Bacon, New York City Department of Corrections, Government.
Jan Hughes, the Family Center, PSRA Committee.
Afternoon, Eunice Casey, HH Center.
Graham Harriman, New York City Department of Health and Hygiene. Matthew LaSure, Village Care, co-chair of Policy Committee.
Kimberly Smith, Harlem United, Policy Committee.
David Martin, co-chair of the Consumers Committee.
Lázaro Paz Gonzalez from HMI and the PSRA Committee.
David Klotz, Planning Council staff.
Dan Hutchinson, Montefiore Medical Center. I'm a finance officer.
Thank you. And I'd like to call on Kimberly Smith to lead us through a moment of silence.
Okay, caught a little off guard on that one, but okay. Let's just take a minute to reflect. It's the beginning of a new year, and it's always good to think about why we do this work and what brings us to this room, and hopefully get some energy to motivate us to the future.
Thank you, Kimberly. Next, I'd like to call on David to lead us through the minutes.
Okay, these were sent out in advance. Are there any changes, corrections to the minutes from last month's meeting? No, none.
Thank you. Right now we enter into the public comment period.
None.
Okay, and being, I see there's one person who wanted to give public comment. And again, just as a reminder, we're holding this to a minute and a half.
Hi, my name is Dominic Romeo from GMHC. Oh, can you hear me? Oh. Sorry. Hi, my name is Dominic Romeo from GMHC. I am currently in HASA, and I wanted to bring up to the board how difficult it has been in regards to the food regulations from our current mayor, Mayor Bloomberg, where the convent that I'm living in now has changed vendors to one of the cheapest bidders to the point where the food has gotten to be unedible. Through the process of complaining and bringing everybody together to try to complain, we've been denied any other options as so far as our food is concerned. Unfortunately, many of us rely on that meal as well as GMHC's meal, and we're very grateful to have those meals, but I'm here to say to you guys, some of these programs that are in HASA, the money that gets funded to these programs are not coming to us. And we are put into a corner where we are told basically you have no rights and you should be thankful for what you get. But and we should be thankful for the food that we get, but if the food is unedible, then then how can we be thankful for that? And as a result of complaining, they're putting each tenant against each other to quiet us from coming to you guys to say, we need help. And it's not just the food that we're talking about, it's the programs that get funded through Ryan White that don't reach us. And I wanted just to raise that to you guys and say, can you guys help? Thank you.
All right, thank you, Dominic.
Good afternoon, I'm Mark. I'm a member of the Action Center, the CAB at GMAC, and my concern today is a little bit off of what he's saying in terms of how funding is reaching to the affected population, especially people living with HIV or even people that are affected by HIV. I'm a member of their family that are living with HIV. But what I really want to hone in on is the matter of housing. I don't need to tell anybody here the relationship between homelessness and the spike in HIV transmission. And I just want this committee, I don't know if you have the power to make recommendation, to speak to the powers that be, that we really would like to see more affordable housing, especially for people that are affected with the virus. Thank you.
Thank you for that comment, Mark. Being that I have no one else on the list to provide public comment, we'll move into the next section of our meeting, which is the Planning Council report. And first up, we have PSRA, the Priority Setting and Resource Allocation Committee. And for this presentation, we will require a vote. Sharon, if you're ready, I'd like you to lead us through this.
Okay, I'm getting ready. Thanks, everybody. So, let's just see. So if everybody could pull out their big spreadsheet with beautiful colors. So I just wanted to start by saying that the federal budget for Ryan White was passed and it was flat funded. And all of us know that flat funding in a context of an economic environment where everything costs more to the top of business doing business continues to rise, but the resources remain flat. So we are not expecting any increases, any significant increases, and we're hoping not to receive any significant changes in the allocation to Ryan White in our area. But as you know, the funding to us is both formula-based, in terms of the number of people living with HIV and AIDS in our region, as well as supplemental, which is a competitive process. And so the actual amount varies from year to year. And we, as an EMA, while the year starts March 1, we have not yet gotten our notification from HRSA as to what is the amount of our award for 2015-2016, starting March 1, 2015. So the PSRA committee last year went through a substantial planning process, and over the past several years, the committee has come up with and has created a methodology for managing either increases or decreases to the award. And so as you just want to orient you to your sheet. So if you look at column E, it lists all the service categories. And those service categories each are ranked on a variety of variables. And then based on those rankings, there is a proportionate either increase or decrease depending on what happens to the overall award to the EMA. So what we did is we used this methodology to apply a potential 5% cut and to take a look at what that would look like for us as an EMA. And let's see. So the spreadsheet is a theoretical 5% reduction scenario. Do we want to go through, should I walk everybody through, David, Jan, the different changes column by column, or
if you like, I can do it pretty well versed.
Okay, you're on.
All right.
Just give us the Reader's Digest version.
Okay, so in column E at the top, you have this year's current award. So we have a total of $103.9 million in this year's award. $3 million is taken off the top of quality management. Then Tri-County gets its portion, 4.7%, and then 10% gets taken out for grant administration. So that left for this year, the year that ends at the end of next month, $77.5 million almost for programs. I'm sorry, $86 million for programs. So in column F, from lines 18 to 35, you see how that's allocated to all of the service categories. That was the approved spending plan, which this council voted on when the award came in, like last June, May or June. There were some minor adjustments over the course of the year. In column G, you'll see the money was just flipped between base and MAI for ADAP Plus. It doesn't change the money that goes to that service category. It's just to balance out the two different awards because we get the award in two parts. Then you see underneath that, about $812,000 was taken out of mental health and put supportive counseling. It doesn't change any programs. This council had approved just reclassifying a number of contracts that provide supportive counseling as a wraparound service in state-funded needle exchange programs because they fit better under the definition of supportive counseling than they do under the definition for mental health, but it doesn't change anything. Then in column I, you'll see there are some modifications to the carrying cost. You'll see in row 25, housing has a bump up of $52,000. That was an additional program. And then because that was all in base, to keep the base and MEI awards balanced, you had to flip that same amount between base and MEI and ADAP Plus. So it lines 19 and 20. That doesn't change anything, how much actually goes to ADAP Plus.
And then you'll see the other reductions in column I, 31,000 for nutrition, 52,000, 10,000 in harm reduction, 55,000 in mental health, 12,000 in legal services, and 343,000 on community-based services. Those are reductions that were made in the course of the year through contract negotiations, contracts that were negotiated for less. But what it is if you go down to the bottom, line 37, you'll see it results in a net savings of $110,000. So the carry cost, which means the cost that it takes to fund this year's programs at their current level going into the new year 2015 that starts in March, is actually $110,000 less. So the first $110,000 of any reduction in the award that we get is offset by the savings in the carry cost. Sharon, do you want to talk about then the proportionate?
So while we don't know what is going to happen, we wanted to use this methodology as a approach in the event that we do receive a cut. So you can see that in projecting a 5% cut to the overall award, based on the higher ranked categories, taking a lower proportionate share of the cut in column N, so it starts at 3.91% and then it goes up to 8%, is how the cut is shared across all of the service categories. So we feel that this is a methodology that has been vetted and has been used and is a good opportunity for us to be able to manage either increases or decreases to the award. And in any sort of reduction scenario, any deficit in what we have would be made up by applying proportionate cuts to all of the different categories, as you see here. So if it's 3% or if it's 7%, we would still use this same methodology. So on behalf of the PSRA committee, I would like to put forward a motion that we approve the methodology as presented.
So we have a motion on the table to adopt the reduction scenario as presented by the PSRA committee.
Oh, I just wanted a point of clarification. This is just in case there's a reduction. We actually already approved last summer as a body an increase scenario when we submit our spending plan for the application. We actually asked for $3 million in additional funding for housing and then another 8% increase in proportionate using the same formula for all the other service categories except for mental health and harm reduction, which we're not expended on. So we have an increase scenario that we've already approved that went into our application, and the person willing will get an increase and be able to apply some of that to this portfolio. So this is just a reduction scenario. Should we get a cut?
Okay. So just to clarify, we have a motion on the table that from the PSRA committee to adopt this reduction scenario. All right. So
adopt the methodology.
Adopt the methodology.
Either to a reduction or to an increase.
Okay.
We want just a reduction. Oh, just a reduction.
Yeah, and because this motion is coming from the committee, it doesn't need to be seconded. So I'd like to open this this up for discussion at this time. And we have Sam.
I was just going to add what David said, but not so eloquent.
Okay. Any other comments or
questions?
Okay. There being none, I'm going to call for a vote. Please raise your hand. If all those in favor, please raise your hand. right, thank you. All opposed? Please raise your hand. Any exceptions, abstentions? All right, one. So the motion is approved.
Let's all vote for an increase.
All right, so next I'd like to call on Matt Lasser to do our policy committee update.
So I think this is the first time that policy committee is actually going first or second since I've been on the council or staff of the council. So I want to thank whoever did the agenda for that. So, I don't even know who this guy is anymore, he's gone. I don't think, if anyone's, unless you've been living under a rock for the last week, you know what's been going on with Sheldon Silver, and pretty much the Democratic members of the Assembly, from what we understand, have pretty much given him an ultimatum to leave his post as Speaker, or it shall be done for him. So we expect that to be taking place when the legislature comes back on Monday or Tuesday. I don't really want to go into all the details around his arrest. It was sort of an open secret, the activities he was engaging in. Anyone who was in Albany on a regular basis like me sort of knew most of this stuff was going on. The extent to which it was going on was not known, but when he was arrested we were like, well, that took a long time. So, pretty much, he probably will not give up his seat, though. I think any of us would fully expect that if it comes down to some sort of plea bargain with the Department of Justice, he'll use his actual seat as a negotiating position with DOJ. So, there's a lot of unknowns with what will happen if Morelli comes in. I know there's been some fear about an upstate legislator taking control of the reins of the Assembly. I'm not personally all that concerned. There are 150 members of the Assembly. 106 of them are Democrats. That's a 2/3 majority. Nothing is going to come out of that chamber that's not supported by an overwhelming majority of the Democrats from the New York City metro area. And so whether it's Morelli or somebody from Buffalo or one of the number of candidates who said they're applying from the city, I think the impact it will have on funding for HIV services, I don't expect it to really matter that much. The New York City caucus will be out in the strength to make sure that our interests are protected. So we can move on. Move on. So, you'll have to excuse me, this was prepared by the health department staff. I only glanced at it a few hours ago. And I'll actually, the staff who wrote this up might want to interject as well. So one of the things we did see around syringe access in the governor's proposed budget is as part of his End of AIDS platform, there are two things that he has proposed in budget language, what's called the Article 7 bill language. One, no more condoms as evidence of prostitution. And the second one, which is that legislation to decriminalize the possession of a syringe, including a syringe with residue of drugs in it. So those are two big sort of policy areas that we were pushing for a long time, and assuming the Republican-controlled Senate does not push them out in negotiations, we will finally have sort of syringe decriminalization we've been asking for a long time. The State of the Union speech. He did use, apparently for the first time, phrase transgender and bisexual equality. Supposedly it was a big deal. Nina, is there anything else you want to elaborate on this? There wasn't any HIV stuff in the State of the Union. It was a pretty bland State of the Union by all other standards.
Yes.
All right. We all know who that guy is. So, as we know, the big deal. So, on the Senate side, the Senate has gone from what was 52, maybe 53 Democrats. It's flipped around. It is now in Republican control on the Senate side. The one good thing, if you want to say, and all that, at least on the Senate side, is that filibuster rules are still in place, and so the Democrats will be able to block legislation. And of course, we still do have a Democrat in the White House for 2 more years. The new makeup of the House is not surprising. It's overwhelmingly white, male, and Christian. I think some issues to be concerned about, for one, is that budget bills, for the most part, have to originate in the House of Representatives because of the constitutional clause around tax issues originating in the House. So budget language generally starts in the House of Representatives. And so there's always all sorts of lovely riders that get added around, no federal dollars being used for syringe exchange, no promo homo stuff. And so those are the kinds of things that we'll have to look out for in the House. Some of our issues around PrEP, syringe exchange, they're going to get harder and harder as the makeup of the House and Senate becomes more and more Republican, and we're not going to have the natural allies. One of the big things around the election in the Senate is we've lost some of our allies. So trying to find a champion for our issues in the House, frankly, with a Democrat who cares. They don't have any power, so we need to find a Republican in the House who's going to champion our issues. And the only one who seems to be willing to do that is Ileana from Florida. And I think she's frankly sort of marginalized by the rest of her party, because I think she had a son who was either gay or transgender, I'm not recalling which. And so we need to find another champion in the House of Representatives. And that's going to be a big challenge. And in the Senate, we have Schumer, but Schumer's got a lot on his plate. And so we need to find somebody else, ideally, once again, on the Republican side of the aisle, in the Senate who's going to champion our issues. And that's the biggest challenge is, sometimes just trying to get the Democrats to do the right thing is good, but if you don't get somebody to really push the agenda, then it's not as useful.
What about Rob Portman? Doesn't he have a gay son?
Who?
Rob Portman? Oregon?
It's Ohio.
I mean, is it Ohio?
Ohio.
It's Ohio.
He has a gay son.
He has a gay son, so just apropos what you mentioned.
I don't even know what this issue is with her from North Carolina and the abortion issue. Do you want to clarify this for me?
Just the woman stood up.
Huh?
The women stood up in the House.
Why don't you speak, Jan?
They flexed the muscle.
Alright, so quick summary on that one. What happened was basically in the House they proposed a bill that would restrict abortions that occurred beyond 20 weeks. It's something that Republicans have been pushing for a while. Long story short, the women representatives in the House of Representatives really spoke up about it across the aisle, both Democrats and Republicans, and they weren't able to pass that bill. So
Here's the key terms. Powerful insurgency. The muscular convergence of women.
Muscular women, that's fascinating. All right, so I think we can move on from that. So we had Andrew Cuomo. I keep wanting to say Mario Cuomo. It's a bad slip. It reflects my age. So Andrew Cuomo, he obviously formed this task force on ending AIDS in 2020. There's some recommendations that came out in the budget. Obviously, there's 2 items I discussed. I was actually expecting that his budget to actually have some more stuff. So if we're going to get to PrEP for all high-risk people, between Medicaid and commercial insurance, that's not going to cover everybody. So we're going to need some sort of ADAP-like PrEP thing. I think they developed one in San Francisco. And if we're going to get everyone to know their status, which was one of his 3 initiatives, there's got to be some initiative around expanded testing. And so the budget was a start to a conversation around getting to where we need to be, but I think it's going to need some work by all of us here who go to Albany to really push the budget to go a lot further than it has around ending AIDS in 2020. Those 2 policy items are a good start. Once again, we have a Republican-controlled Senate that may not be so inclined to decriminalize syringe possession, so we have some work to do on this. Luckily for us, though, his State of the State, though, he did put a bullseye, and it was not us. And so Albany is going to be very busy with all sorts of attempts on education reform. which will definitely tie up legislators' times, but it does mean it gives us, healthcare is not on the agenda, it's not on his radar, and so it'll give us an opportunity to really push that issue where no one else may necessarily be talking about healthcare items because it wasn't really something he was targeting. Yeah. Oh, right, sure. This is what happens when I'm first. All right. I don't know what this thing is about. We can move on from this. Is he the new appointee? Oh, the chairman. Well, we can all read. I could read this aloud, but okay. I'm sorry, you told me I was out of time, so we're moving on. Keep going. So the Affordable Care Act, I think, everyone was always worried about the lawsuit that came up 2 years ago, and everyone thought the Supreme Court was going to strike down the ACA, and by a 1-vote margin. The Supreme Court did not do that. And while this particular case has not gotten as much press coverage, the fact that the Supreme Court is willing to take it up should be a point of concern. If the Supreme Court rules, because frankly, I'm going to fully admit, if you read the section in question, it literally does say the tax credit should only apply to state-based exchanges. So if the Supreme Court were to do a literal reading of the statute, they would say, I'm sorry, everyone in the federal exchanges, you are not eligible for a tax credit because the law doesn't say you are. Somebody made a mistake in the writing of the bill. Under normal circumstances, there would be an opportunity to amend it. Of course, this is not normal circumstances with this law. So if the Supreme Court applies a literal interpretation of what the statute says, that means half the states in the Union, a lot of which were in the South, are automatically going to lose their tax credits. And barring those Republican governors entering around and saying, oh, I'll do the right thing and create a state-based exchange, it could completely undermine the law. And what you could wind up with is, once again, a healthcare delivery system where people in the East and West Coasts have good healthcare and people in the South have lousy healthcare access, which is what we've had for the last 100 years. And the ACA was really an attempt to try and equalize that, and if this ruling goes the way it could, we're going to be back to a fully federal system with states in one jurisdiction having great healthcare coverage and states in others having pretty much the old status quo. So that's something to be concerned about. And if that does happen, I think the pressures on Ryan White could be tremendous. The South will be saying, we really need this money. You guys do not need this money here. And if you follow the logic pattern, there's some logical sense that it's sort of twisted, but it's going to put a lot, and when you have a Republican-controlled House, which is, John Boehner's from Ohio, but a lot of the leadership is from the South, you got to think about where the political realignment is taking place. It's moving down into southern jurisdictions, and the implications that could have for any attempt to reauthorize this program, with this makeup, with a hugely disproportionate healthcare delivery system that this court ruling goes, it could have a ripple effect to Ryan White. Okay. So the long term, I'm not quite certain why this is a policy issue, but it's the last slide. And as someone who's been living with HIV for over 10 years, I'll say, okay. And I was told I was out of time, I'm just going to shut up.
Thank you, Matt, for that lively presentation. And so next up, I'm going to call on either Chris or Lisa to give us an update on the integration of care committee.
Can I just ask Matt a question?
Sure, go ahead. No.
What about the sign-on letter that came from the past?
Oh, for Ryan White.
Yeah.
I believe Adrian and I had communicated that we thought the policy committee was acceptable for the policy committee. I'm not certain where it is at this point beyond that.
It's in the packet. Right after the policy material.
After the PowerPoint? Policy committee? Ryan White work group.
So what's the process we need to sign on to this letter?
So, I move that we sign on to the letter.
Or did we sign out already?
is a letter from the Ryan White Work Group, and it was actually brought to the attention of the Policy Committee co-chairs by Sharon Duke and co-chair of PSRA. And this is a time-sensitive issue, so we bypassed the full Policy Committee and just got the approval of both the Policy Committee co-chairs, Matt and Adrian Guzman, to bring the letter before the full Planning Council. This is a sign-on letter. It is not a letter that originates with this council, so we cannot make adjustments to the language in any way. The focus of the letter is on not engaging in reauthorization at this point in time, rather maintaining the Ryan White Care Act as is until we have time to fully understand the impact of the Affordable Care Act on patients living with HIV.
There are 300 organizations that have signed up to this letter. And we've been encouraged to sign on to it as well.
I'm going to play devil's advocate here. No, I said it's the co-chair policy committee, we should sign on. You know, when Emily came from her side, she gave us a laundry list of things thou shalt not do. Is this in that list?
No.
The list of activities in which we cannot engage includes appropriations and pending legislation. This is not pending legislation. Rather, it is saying we should not rework the right. We should not go for reauthorization. We should not try to rework the legislation in any way. We want to maintain the status quo. So I maintain, Jim maintains that this is not pending legislation.
I just thought I would ask.
By all means.
There are other planning councils listed in this list. So you need to make a motion on behalf of the committee.
Okay. So on behalf of the policy committee, I've introduced a motion for the planning council to sign on to this letter.
Okay, so we have a motion on the table from the policy committee to sign on to this letter. Any discussion?
I just wanted to also say individual agencies in New York, if you want to bring it to your executive directors and encourage them to sign on behalf of your agency, like Harlem United did and JMHC and Healthcare Network, I recommend that you do that as well, and I do think that it would be wonderful show of support for the Planning Council to sign on. So I support the motion.
Yeah, Village already signed on, so.
And Matt, do you have, or Nina, can you distribute the email address for agencies to sign on?
Yeah, we're gonna cover
It's
your
not
grant.
indicated in the letter.
Okay, we can do that.
All right, thank you, Sharon, and everyone else. Any other discussion, any other comments? All right, seeing none, I'm going to call for a vote. All in favor of the motion that's on the table, please raise your hand. Thank you. All against? Any abstentions? 1, 2, 3. All right, motion passes. So, thank you. That concludes the policy presentation. And next, I'm going to ask Lisa or Christopher to do the presentation for the integration of care committee.
Great, thank you. Lisa's not here today, so I will be taking the lead. Thank you to Nina for putting together these notes for me. The IOC has been discussing early intervention services and has listened to quite a few speakers in the last couple of months on some of the following topics, just to keep you guys updated. We had an overview of the service categories under the Ryan White Care Act and Ryan White Part A portfolio planning, early intervention services, and selected large EMAs across the country, HIV testing and linkage to care in the New York EMA. Dr. Dimitri Daskalakis gave us a presentation on his proposal for HIV one-stop in the city STD clinics. The health department assisted HIV partner services and linkage to care strategies that they use. And we had a panel of current providers who are field providing these services, notably frontline staff that are providing those services. We will be, again, next week, writing the revised or the new directive. That's February 4th, Wednesday, from 10 to 12. Recently, we also formed a task force to amend the current legal services contracts. The legal service providers want to be able to offer immigration legal assistance in light of President Obama's executive action on immigration. With the assistance of immigration legal services, we know that some immigrants may become eligible for Medicaid or HACA, reducing the number of Ryan White clients and making room for individuals who truly have nowhere else to turn. Some legal service providers from Tri-County will also be joining the task force, and that task force will be meeting Friday afternoons for the next 6 weeks, starting tomorrow. And if you would like to join the task force, I've been asked to give you Nina Rothschild's phone number. And if you guys have a pen, I can give it to you now. That's 347-396-7447. Again, that's 347-396-7447. I will note that later in the year, we will be revising the service directive completely. This is just a request to amend the current. Yes, it's in the task force.
It's just that
You don't have a need for it, but
Ryan White Part A Legal Services Task Force.
There we go.
And we are meeting by conference call, not in person.
Yeah, it'll be a conference call. That's all I have.
Thank you, Christopher. Matt?
So I think I'm glad to see that there's some changes being explored for legal services. And as someone who's showing his age, wasn't there a long time ago, didn't legal services used to have a much broader purview? And then based on what I thought were directives from HRSA, they were required to change what they could and could not do for legal services. Has that policy changed, or am I misunderstanding history?
Join the task force.
I have enough committees.
We've gone back through all the history of our correspondence on that topic, and we're going to be examining that through the task force and looking at the current service directive as it stands. We believe that this is up to a local jurisdiction to shape those services, and so that's what this work is going to be over the next 6 weeks.
All right, thanks, Shannon. Any other questions or comments on this before we move on? Okay, so I'd like to call on Dan to give the Finance Committee update.
Good afternoon. So, just to review through, as we're closing out, coming close to the end of the 2014-2015 finance and budget cycle. So just that everyone in the room is aware is that the Planning Council, the budget is around $890,000 per year. So in light of the landing short of $104 million, that we use less than 1% for administrative costs to support the staff of the DOH, and then some of the other OTPS things is that they do a really excellent job with the very lean resources. So they should all, I mean, the presentations with all the nice graphics and everything that's put together and all the planning, they really do a lot with not much. So we should really be grateful for all their hard work. So, thanks, guys, and gals. So as we're coming to the end of the year, of course, we want to spend every single penny that we have, and because of a couple things, I think one was, so we had like underspending in the Planning Council budget, not a lot. I think some of it is due to that the city recalculated the fringe rate for the Planning Council staff members from 51 to 48%. Is that right? So there's a little savings there, and then because the appointments to the board, to the council were a little bit delayed, some of the meetings didn't happen, so we saved on some of the space and some of the other audio visual. So there's a little bit of savings that we need to get out the door, otherwise, yes, we just need to get out the door. So last week or a couple weeks ago, January 13th, the Finance Committee met, and then subsequently the Executive Committee met, and we approved the following items after a discussion to assist. So there's $5,000 that is set aside to pay for the Planning Council retreat on February 26th. My understanding is there hasn't been a retreat in several years, and given that, including myself, and there's many Planning Council members, we thought it'd be a good opportunity to take the day to spend together to talk about everything that we need to talk about, and rather than in this, just an afternoon that we have. So the Planning Council staff also identified some of the equipment that they use. So they go up to, as many people know, up to Westchester, the Tri-County meeting, and they have to do some work there, so they need an additional laptop. They need a tablet computer to facilitate some of the work that they do mostly up there, and also a digital video recorder. So based on how wonderful they're doing and the reasons they need this stuff, the Finance Committee approved it, and subsequently the Executive Committee did also. Does anybody have any questions or comments? So in your packet there is the Planning Council budget, and there is the approved items. So on behalf of the committee, I think this is awesome. I'm making a motion that the full council approve the expenditure of these items that are listed on your handout entitled Fiscal Year 2014 Planning Council Budget Modification. So it's got the 4 items listed.
So we have a motion on the table to adopt the budget as presented from by the Finance Committee. All in favor? Any against? Right? Approved. Next up is David Martin with the Consumers Committee.
Good afternoon, everyone. I'm glad to be back. I was away, had some knee surgery, but I'm walking better now. And I want to thank Daryl for the talking points for the Consumers Committee. On Tuesday, January 20th, the Consumers Committee met, and we were at the offices of GMHC. They hosted our committee meeting. Thank you to everyone over there who made that possible. During our meeting, Randall Bruce was elected by acclamation to his 3rd term as a consumer at large, and it's a role he has filled diligently since December of 2012. Also, a new 2014-2015 Planning Council appointments were announced. Of those 15 new member appointments and the reappointments, 7 of those individuals are consumers living with HIV or AIDS. Consumers were invited also to participate in the Power of Quality Improvement Conference, which was going to be on Tuesday, January 27th. But because of that destabilizing blizzard we had, which never manifested, they had postponed it just to be safe. It's going to be at the New York Academy of Medicine. I've been told that they will reschedule it. But I am also co-facilitating a track during that conference about consumers in quality improvement. And it should be a lively discussion. I just wanted to tell you some of the, there are 4 workshops during that portion of the conference. And one is the needs of women who are HIV positive and developing groups that meet their need, dissemination of information and an increase of understanding of Hep C and the HCV treatment options, the consumer/CAB engagement and quality, where I will definitely be presenting the findings and recommendations of our 2014 CAB recommendations and best practices survey. And also a topic of healthcare stories, the Healthcare Stories Project will be shared, which focuses on patients' perspectives on quality of care. Let's see. Also, so I hope those of you will come out to that conference, and definitely you will get emails or notification of when the rescheduled conference will be. There was also a brief review of some literature regarding successful linkage to care service models. And this discussion will be continued in our February meeting. Also, we had a lot of participation from consumers at GMHC, and they came to that meeting. And we also always welcome new voices to the table and invite any of you, as well as those that you could recommend, to come and participate. Thank you.
Thank you, David. Are there any questions or comments for David? No? All right. Seeing none, I'd like to invite Daniel Castellanos and Carrie Davis. Daniel, to give an update from the Needs Assessment Committee.
Thank you. When people think about data collection and data analysis, it doesn't sound very sexy, as budgeting does, but it has a real impact on people, from consumers who have to answer their intake forms and reassessment several times every year through several organizations, and they have to bring all the documentation through the service. To the service providers who have to collect the data, clean up the data, enter the data, and then submit it. To the Department of Health, who has to collect the data, clean up the data, and then send it out to the federal government. So we compile a lot of information, and we feel that the Needs Assessment Committee, we feel that it's been underutilized, and what we want to do moving forward is to utilize that data even more and work on ways of disseminating the data to service providers and also to consumers. So that's what we are going to be doing in this spring and summer. Hopefully we are going to be producing reports that are very accessible to people and that are also backed up by peer review articles and peer review reports. So that's our plan that we are working on. But we need the help from service providers and from consumers who can come to our meetings and can tell us, this is what we want to know, this is what we are seeing on the trenches, this is what we are seeing on the streets, and we want to see more data analysis on this. We want to see if that's what's happening across the city. So this is a PSA for people to come to our meetings and express your interest on learning more about services, service patterns, about needs, and about distribution of resources and all that. So please help us with that. In our next meeting in February, we are going to be discussing what are some of the main questions that we have right now in terms of data coming from eShare and also from the chain study. So please come to our meeting. The second thing is that last spring the council recommended restarting the chain study in the Tri-County area, and it was a recommendation that was added to the Needs Assessment report. What we are doing now is following up on that recommendation we have submitted. We discussed that in its assessment, and then we discussed the issue in the safety committee, and in your packages you are going to find a letter that was sent to the Department of Health asking for information on restoring the Tri-County chain study. And I think that's it.
Any questions or comments? No?
Mike, do you have anything to add?
No, I'm just amazed. Nina makes such a wonderful outline, and you just go off and improvise such a wonderful report. Thanks.
I hope that's a compliment.
All right, thank you so much, Danielle and Gary. So I'd like to move on now to the Rules of Membership Committee and call on Daphne Hazel to give us that.
It's going to be a quick, report and update that the Rules of Membership Committee will be calling a meeting soon, probably in March, in order for us to review the bylaws and amend them so that we can fully incorporate the Tri-County Steering Committee and the Standing Committee of the Council. So everyone knows that that Department of Public Granting would now be administering, overseeing with the input of the Planning Council, Tri-County. So we have to incorporate that within the bylaws. You want to comment?
I'll comment in there.
So we'll let Graham give a full update on that in a few minutes. So but before that, I want to turn it over to Jan.
Okay. Thank you, Dan. We have a strategic planning retreat coming up. It is scheduled for the last Thursday of February, when we would normally have a planning council meeting. And it's the first that we've had in a while, and we did identify some unspent funds in our budget, so we were able to underwrite the retreat. Emily Gans McKay, who's been here a number of times, has agreed to facilitate the meeting. If there are people who are interested in working with me and the planning council staff for a couple of phone calls to shape the agenda of the strategic retreat, would you please let Nina know at the end of the meeting? Thanks.
Thank you, Jan. And now I'd like to turn it over to Graham and Tom. No, Tom's not here. Sorry, to Julie. To Julie and Graham to give us an update. The granted report.
Let's have Julie start with the Tri-County report, and then we'll come here.
Well, in terms of what we're doing in Tri-County, all the year 25 CFAs are in, and we're currently reviewing those to be ready for March 1st to go to contract with all of the programs in Tri-County. Another big thing has happened in Tri-County, and that is that Tom Petro, who has been the administrator of all programs in the Tri-County, which includes Westchester, Putnam, and Rockland counties, has announced that he will retire effective in March, which is only a few weeks away. I can't take it. Anyway, with Tom retiring, we're talking to the city about how to continue programs in a seamless way in the Tri-County area, and also to provide a voice for Tri-County in and amongst the many voices of New York City. Tom, of course, as you know, has been an advocate for Tri-County for years and years, and his voice being the loudest, but supported by many others. And it is his desire, and I think also with the city, to make sure that Tri-County continues to be heard and to contribute to the entire EMA as well. Tom will be missed, not just by Tri-County, but you may not be aware, Tom with a group of other pioneers wrote the first Ryan White application that went to HRSA. And he was one of the first to get money to provide services for people living with HIV and AIDS. So not only is Tom missed at Tri-County, Tom, an advocate for people living with HIV and AIDS, will be missed, although I don't think he'll disappear completely.
So Tom did let us in the grantee's office know that he was retiring. And so we've been in conversations with Tri-County about how to manage this transition. We aren't in a place where we are clear about what that transition looks like, but we're in discussions and we'll be able to report on that transition as it develops. But certainly I want to say that Tom every single year reads the grant application and gives the most concise and specific and helpful feedback to our grant application. He really has an amazing talent for editing and for ensuring that we follow that guidance. We have a number of people that do that on the team, but he's really one of the best, if not the best at doing that, and we're really going to miss his input. He really has been an incredible advocate, not just for Tri-County, but for all of the community. We really want to thank him for all that he's done. So I'm going to launch into the other pieces of the grantee report. The 2015 award, once again, HRSA has indicated that we're going to receive a partial award early in the grant year and full awards later. We don't have any specific information about the portion of that partial award, what portion of base, what portion of MAI like we have in the past. We've been told that that information is coming. And I have reminded them that they need to send that to us, but we haven't received it yet. So this makes it difficult when we issue initial contracts because we don't have firm maximum reimbursable amounts for those contracts, and that creates a challenge. We have, as Sharon had said earlier, we have indications that we're likely to be flat funded, but we don't know until you know. So it's a bit of a challenge on the part of PHS for renewals with our new contracts. So it creates a hardship all across the nation when this happens. And so we're managing, and PHS is managing that difficulty. In August of last summer, the Planning Council authorized the grantee to request carryover funds from FY 2013 to 2014 and allocate them to ADAP, outpatient ambulatory housing services, and medical transportation. Historically, when we've have not had the full amount of unspent funds in our possession due to recoupments late in the year, HRSA has permitted a partial carryover at that time. And then at the time that carryover requests are due, and a second request then when those remaining funds become available. Despite this precedent and assurances that we would be able to spend the funds before the end of 2014, HRSA HAP Grants Management has denied our second request. So the grantees had extensive conversations with HRSA Grants Management and our project officers, and we've attempted to appeal this decision, but we've exhausted all options. So what this basically means is that of the $621,000 in unspent funds, we are able to carry over $516,000, so the majority of that money. We have $104,000 that we will not be able to carry over as a result of this decision on the part of HRSA. So it's to more closely implement the carryover plan, we as the grantee identified $46,215 in administrative funds and transferred them to the Tri-County region for housing services and medical transportation. And the only service reduction in 2014 as a result of this HRSA's carryover decision is that ADAP received $58,000 less than their carryover allocation. So it's not ideal. It's less than ideal. HRSA has always said that it is up to them whether they approve this carryover, which is why we are always very careful to not have a lot of carryover. And historically, many thanks to the hard work of PHS, had very little carryover at the end of the year, given that we have a $103.9 million grant. I hate to be the bearer of bad news, but we've tried, and we went back to HRSA, and we tried to get this money back so that we could send it over to ADAP, and we were unable to be successful with that. But the bulk of the money, $516,506, was carried over from last year. We issued the results of an RFP for 5 service categories. You see the results of that RFP in your in the grantee report. I won't spend time going over all of those awards. You can see them for yourself, but it includes health education risk reduction awards, non-medical case management for people who are currently or recently released, currently incarcerated or recently released, general non-medical case management, supportive counseling and family stabilization at syringe exchange programs, as well as general supportive counseling and family stabilization. As David said, our upcoming, or our quality management conference that was supposed to be on Tuesday was canceled due to the snow. We're looking at hopefully a February date, but we'll get back to people once we are able to confirm that date. We're very excited about this conference. It's the first time we're doing it. It's a collaborative effort between the AIDS Institute and Public Health Solutions. Providers have been, and consumers have submitted abstracts, as David referred to, went through a review process, and we really are excited to have that conference when we're able to have it without snow. There is an interagency quality management meeting that I'd like to invite you all to. It happens on a monthly basis where we go through service category quality indicators. And it's a helpful place to find out sort of what's happening in terms of quality indicator data in our services funded by Ryan White. If you're interested in that meeting, give me a ring or contact Jan. We're going to have a webinar in regards to emergency preparedness in response to HRSA recommendations, also in response to just what we find from the health department is best practice with our providers. We're strengthening the emergency readiness requirement in Ryan White contracts to maximize the safety and preparedness of Ryan White client staff and facilities. So we've been working with emergency preparedness at the DOHMH to identify best practices and capacity building materials to develop an emergency preparedness assessment. So we'll be holding a contractors webinar next week. We're looking forward to that. We are in receipt of the letter from the executive committee. We've had a number of meetings, and there are a number of aspects in regards to future additional support to train, and that's as much as I can share. I will provide a written response within a month after I have several meetings to iron out a few details. But one piece that I do know that we can do is there is some unexpended money in the Planning Council budget, and we will be committing that to change. So I'll give a full report at next month when I have all the other aspects of the plan in place, and I look forward to letting you know all the specifics of what we're working on with the change. Any questions?
Sharon?
Jan, any chain in Westchester?
Change?
Any change?
Yes, Tri-County cohort,
Tri-County.
yes.
Oh, so this is,
This is, we're working on a plan
Working on
to
getting
respond to the letter that has requested that we reinitiate the Tri-County cohort, Tri-County chain effort. And so we're working on a number of different pieces of how to put that back together, and I will report in a month.
Any other questions? All right, thank you, Jack.
Okay, so this is our third year in our comprehensive strategic plan, and we're going to have a presentation on this. Why is this important, and why do you need to know this? This is really, once a year we come back to you, and we share with you a number of indicators as to what our progress is in engaging people in care, how their health outcomes are measured and determined, and are we improving? The comprehensive strategic plan is based and framed around the national HIV/AIDS strategy, and all the elements in that strategy are reflected in the plan. And so we're on the same trajectory as the national AIDS strategy, and in many indicators we're ahead of everybody. So this is good news, and it's time to share that. And Stephanie's here, and is Stephanie and Mary here, or? So Kate's presenting this, and Kate is with the OHMH and a great colleague of ours and on the Needs Assessment Committee. Thanks.
Hi everyone. So as Daniel mentioned, data analysis and collection aren't always the sexiest of things, so I'm going to try and keep this interesting this afternoon. Again, I'm with the Research and Evaluation Unit at the City Health Department. So in this on just a little bit of background for those who aren't familiar with the comp plan. So it is a requirement mandated in the legislation for Ryan White Part A that every EMA must come up with a comprehensive plan for Ryan White services. And it's periodic, so the most recent plan was covering the period of 2012 to 2015, and it's meant to measure progress over time and also think about priorities and planning and looking forward in terms of what the goals of Ryan White Part A services should be. So the most recent plan was approved in 2012. The indicators were developed and finalized the health department, but again, the final decision was made by the planning council. So all of those indicators have remained the same by and large over time. And each year we provide an update with the most recent year's data, again, on all the indicators. The comprehensive plan itself is a much bigger report, and again, it's on the Planning Council website. And we provided things in a couple of different formats. So I'm going to present a short version of the comp plan update in your packet. There's also a long version, which has more graphs and charts. And then for those who are less excited about the graphs and charts, there's also a 3-page summary handout, which again just explains in words, again, the big trends, where the data comes from, and maybe some of the thoughts behind why things look the way that they do. So again, just in terms of why we do this every year, there are concrete targets, so it helps to focus a little bit in terms of progress over time. There's a comparison between how Ryan White Part A clients are doing in comparison to all people living with HIV in New York EMA. And also it allows a little bit of reflection on what factors may contribute to changes over time. There's a little bit of frustration over this because the comp plan is a snapshot, it's a big picture, so it's not looking at effectiveness over time. The whys for this are really, this is sort of supposed to spark conversations on the whys, but it doesn't really explain that much. It sort of gives you just a bird's eye view of how we're doing at the time. And then also just gives a little bit to think about. If the landscape has changed over time, could things, could services be adjusted quickly in ways that would maybe make the services more effective? So again, just a brief demographic summary for 2013, which is our most recent year of data. There are just over 120,000 people living with HIV in the New York EMA. including New York City and Tri-County. And of that, Ryan White Part A, they're just about 20,000, just a little bit under. The demographics haven't changed that much over time. So the overall population of people with HIV and Ryan White Part A clients are disproportionately male, identified as Black and Hispanic, and the population is shifting to older, so 40 to 59 years of age is the largest age group. Ryan White Part A clients are a little more, are a little different in some ways. So there are more female clients, more clients who identify as Black, and more clients who are under age 50, so slightly younger. And then this is the first year that we have some demographic data from Tri-County, and for those who are interested specifically in the Tri-County area, the longer version of the presentation has a bunch of graphs. Again, we're limited by and large just to demographic data at the moment, but the population in Tri-County seems to be a little bit more, a little bit older. There are more white clients, and there's a higher proportion of female clients than the Ryan White Part A population in New York City. I'm going to go over specific indicators. There are a lot of them, and I'm just going to highlight certain ones. And then there's an overall summary at the end. And these were developed in 2012 based on National HIV strategy, the data that was available to us at the time, priorities, again, in services and planning council. So some of these, again, this is actually a really excellent example of one that probably the next round of the comp plan, which is coming up soon. This indicator probably isn't a great one. But I'll walk through all of them and explain sort of some of the changes over time. So this first one is to look at ensuring expanded access to voluntary HIV testing across healthcare and social support service provider settings by the end of 2013. We go to the next. So each of these you'll see there's Ryan White graph on the top and the EMA graph on the bottom. Where we have data for Tri-County, it's specified, it'll tell you whether it's just New York City or Tri-County or both. Ryan White clients are people who are receiving services, so they're people we can tell from who share are receiving HIV services in New York and people who make it into that bottom red chart are people who show up in the New York City registry, so people who are receiving HIV care by and large in New York City. In the boxes you'll see is a target and again the trajectory in terms of where we've come each year in terms of reaching. So I wouldn't worry so much about the slope, but more are the numbers going up and down over time and have we hit the target or not. So you'll see for Ryan White, for testing, the testing numbers have increased over time, but we haven't hit the 2013 target. The EMA over time, the opposite trend is true, so the number of people tested has actually gone down over time, so we're below the target. Again, this may not necessarily be a bad thing in the sense that testing is now covered through the ACA and through Medicaid, and so as people have a wider range of access to testing through different means, both funding for testing through the health department and through sort of standalone sites has gone down. But that may again just be an indicator of people having access to testing elsewhere. And so again, there's a lot of focus on linkage to care and getting people who are newly diagnosed into care quickly after their diagnosis. So if we look at the graphs for these two, again, as you'll see for Ryan White, which is the top one, rates of linkage to care within 3 months of diagnosis. So again, this is for newly diagnosed clients. It's gone up over time. Again, the target for 2013 was 8%. We didn't hit that, but we're at 76, so pretty darn close. The AMA, again, the rate stayed pretty consistent over time. The target there is also 80%, and we're at 72. So again, close, but didn't quite make it. The next one is looking at retention in care. So this is for not just new diagnoses, but all people living with HIV. So again, there's a big initiative not only to link newly diagnosed people to care, but also thinking about how to keep people in care and how to re-engage people in care. So retention is kind of a measure of, are people consistently getting HIV medical care? And so again, if you look at Ryan White, the numbers are really high. And again, this raises questions in terms of, are they really high because Ryan White clients are sicker and therefore getting more care because they need more care? Or is it a question of, because there's so many supportive services and there are requirements around the supportive services, people are actually getting into care more often? And again, this is a snapshot, so it tells us the numbers are going up, and the why is a bigger question to figure out elsewhere. In terms of looking at the New York EMA as a whole, again, the numbers have been pretty flat over time, but 82% of people are consistently in HIV medical care, which is, again, very high above the target in 2013. And if you look nationally, people are doing much better than many other people.
Excuse me, what is the definition of retention in care? Is it a number of months or?
Yeah, so it's 2 medical visits that are 3 months apart within a year. So they can be spaced anywhere within that. At least. Yeah, and if there are other questions, as I'm going to.
Yeah, I had just one on the demographic summary. Could you just explain to me again the difference between the third and the fourth?
Okay, so the third meaning.
Bullet?
The third bullet and the fourth bullet, I didn't understand it saying majority of people living with HIV Ryan White clients were male, and the second one says.
So there's first it's comparing. So it's comparing all Ryan White clients to all people living with HIV. Then the next part is comparing. Yeah, so basically it's saying among both of those groups, the majority of people are, a higher proportion of men, higher proportion of blacks or Hispanics, and higher proportion of older clients. But then if you look sort of closer down, among Ryan White, there's a larger proportion of men. There's a slightly larger proportion of women than among all people with HIV. So
in other words, the Ryan White Part A client base has more women than the overall population of people living with HIV.
And it might help, so the longer version, if the words are confusing, which I think they are, the longer version has pie charts. So you'll see it's basically a question of men still make up the largest slice. They just make up a slightly smaller slice for Ryan White than for all people living with HIV. And then the very last one is comparing New York City and White. Yeah. The next. And this is, so we looked a little bit at how things varied across clients enrolled in different service categories. And so again, for retention and care, you can see that across all service categories, retention is very high. And it tells you a little bit more about the populations that might be enrolled in these service categories. So retention is lowest for people enrolled in home and community-based healthcare, which again makes sense in a certain way because you would think that people enrolled in those services may be less mobile, may be less able to get out and access care. So, but again, the rates are still very high. So, but it tells you a little bit maybe about the different people accessing different services within Ryan White. Again, there's a big focus on biosuppression. So this is just looking at biosuppression with basically anybody who was had those 2 medical visits in a year that were 3 months apart. Did people have at least one viral load that was under 200? So this has a longer target, so the target is set for 2014. Just again, because the thought was that this would take longer to achieve. And you can see that for both Ryan White and for the EMA as a whole, the numbers are increasing slowly. And again, particularly with things like the guidelines changing, so that everyone is sort of offered and encouraged to be on antiretroviral therapy after diagnosis. The thought is that this will continue to go up. And I'll talk a little bit more about this in a minute. Again, if we look at service categories and how clients are doing across, there's a little bit more variation than retention and care. And again, our thought is that this says more a little bit about the populations enrolled in these different service categories. So to be enrolled in care coordination, you either have to be newly diagnosed or have some things that complicate adherence. So the fact that they're among the groups with the lowest rates of viral suppression, again, makes sense a little bit. This is again looking at all the indicators in the comp plan, just as a summary. Looking both at whether the targets have been met so far for the Ryan White population, for the EMA as a whole, and on the far right is looking at the trends. For Ryan White and the EMA as a whole, green basically means that something has been met. So you'll see that the targets by and large for all indicators have been met for the EMA, but not for Ryan White. But the good news is that, again, if you look at all the green on the right, so though the targets haven't been met by and large for Ryan White, things are definitely moving in the right direction. So it's just a question of things being slow. And then goal 4 for the comp plan is a sort of overarching look at disparities. And again, trying to ensure that all groups have equal access to high quality HIV care. And again, this is just a limited look at specific groups, so obviously in terms of, you could go into much more detail in terms of the different groups that you could look at. But this focused on gender, age, race, ethnicity, and then location based on district public health offices. So we look at disparities by gender. As with many diseases, getting men into care and getting them to stay in care is a little bit harder. But viral load suppression rates are consistently lower among women. For age, men are consistently more likely to be diagnosed at the same time with HIV and AIDS. But linkage and retention in care and rates of viral suppression are lower for younger people. Looking at race ethnicity, concurrency rates, again, the dual diagnosis of HIV and AIDS, and retention in care were higher among those who identified as Black and Hispanic. But at the same time, again, rates of viral load suppression were lowest for those who identified as Black. And again, this is, the differences aren't huge, but it's I think it's worth noting that people can be highly engaged in care and yet not virally suppressed, and that one doesn't necessarily lead directly to the other. You see a similar pattern if you look at location, so concurrency rates tend to be higher among people living with HIV in DPHO areas, and rates of viral load suppression are lower for people living in those areas.
Could you clarify what DPHO stands for, please?
Yep, it's a district public health office. So again, this shows a little bit of the history of the comprehensive plan. So in 2012, district public health offices were I think just sort of becoming a big presence, and it was a way at the time that was considered how to measure populations or neighborhoods with high need. And I think those offices still exist and are very much functional, but I think the measurement of high need has shifted a little bit more to things like area-based poverty and other measures of income. But at the time, that was considered a way to sort of think about areas where people might be. One thing I will say is that particularly if you look at viral suppression, which has the largest differences between groups. Despite the fact that there are disparities, you see improvement across all groups over time. So again, that's good news moving forward, that yes, the gaps remain, but the overall trend is a positive one for everyone. And this is the last goal of the comp plan, this economic evaluation of Ryan White Planning Services. And again, this has been continuing work in many different iterations. The most recent was with a group of capstone students at NYU who did a bunch of analysis looking at just the range of services people were receiving and cost. And I think there's a lot more that needs to be done on this, because the basic message for that was that you had people using all levels of services. So some people who use one service, some people who use 100. People who use mental health services were not uniform in the sense that some people were using group sessions and some people were using individual sessions and some people were using other types of services. So you have a variety of services being used, a variety of levels of service utilization, and then agencies are being reimbursed at different rates for those same services. So it's a patchwork of things going together, and there's a lot of work moving forward in terms of trying to find some way to standardize the rate and think about what an average cost per client would be. And there'll be a summary paper coming out in February to be distributed here that just explains the work that's already been done. And then moving forward towards the end of this year, again, more work in terms of thinking about different service category levels and what an average really means for those different groups. And that's it. Again, there are a lot of people moving parts for this in pieces that put this together. So thanks to all of them.
Thank you, Kate. Do we have any other questions or comments on this presentation? No? All right. Just turn that.
This is a period for public comment. We have those in the audience who are just walk up the microphone and introduce yourself.
And as a quick reminder, we're going to keep the comments to a minute and a half.
Hi, Dominic Romeo again. Thank you guys so much for getting all this together. It really does show me that there is some hope. I became HIV positive not so long ago, and instead of just victimizing myself, I decided to join and do as much as I can so far as the cause is concerned. But you had mentioned a few things that caught my eye. And I feel like one of the major things that I've been noticing as a person who has HIV, and also I had Hep C as a result of drugs, is we have a problem with repackaging things, how we go about presenting things. One of the things that you mentioned, which is a cause of mine, is the needle exchange program, which on paper looks great. But to be honest with you, because of that needle exchange and being a drug addict, that actually gave me Hep C. Because at the end of the day, a drug addict doesn't know one needle from the next. And it's one of the causes that I've been personally involved in, trying to solicit some of the companies that make these needles to actually make them color coordinated, to have at least 4 colors to choose from. Because when you're up for 4 days as a drug addict, you don't know what day it is, let alone what needle you've used. And I think that's a consideration that this council needs to pay more attention to. It's a great idea at the end of the day to want to do these things for people who are addicts, but as an addict, I got Hep C because of it. So let's go outside of these ideas and make them better. The other thing is PrEP. At the end of the day, basically what we're doing is just encouraging other people to have more unsafe sex. Another, again, a great idea, but without proper instructions, you should be, as a physician, you should, if you want PrEP, you should have to go with your partner. You should have to prove that you're in a relationship. And this goes along as well with boner pills, as we like to call it in the gay community, which is Cialis or Viagra. They should be regulated, because as a drug addict, it's really hard to get hard. And that pill makes it easier to transfer the virus. So I know I've said a few things that are sketchy, but at the end of the day, we're not addressing some of the things that really need to be addressed, which is the drugs, which has brought many of us to our knees. And we can manicure as much as we want with items like PrEP or cocktails that are just coming out at lightning speed. At the end of the day, I've seen no evidence with the planning committee, and this is no disrespect for any of you guys here, I'm sure you're doing as much as you can, but I see no evidence that's trying to end this disease at all. All we've been doing is manicuring it. We're manicuring it, we're not curing it. We gotta get back on that message. Thank you.
Thanks for that comment, and
In our effort to end on time, do I hear a motion to adjourn?
So moved.
Thank you.
If anyone needs Metro cards,